Dr. Giovanni, the session is yours.
Airway management, and I will tell you about it. Please, next. Okay. I hereby reported the guidelines by the Italian Society of Anesthesiology and Intensive Care, as we have to minimize the exposure and the aerosolization of the virus. We have to consider early intubation. Of course, when dealing with the airway of a positive COVID patient, you have to wear your PPE. As Alessandro earlier stated, the PPEs are high protection certified masks with N95 or PP3, Foxtrot Papa 3, a face shield, a waterproof gown, and 2 pairs of gloves. Always remember to wear 2 pairs of gloves, because every time you touch a contaminated surface, you have to take off the outer layer. So it is very important. If you have a negative pressure room, intubation should be placed there. If not, if it is not available, just shut down the door and don't let unnecessary people inside the room. As for the technique, the rapid sequence intubation is quite advisable, because you have to minimize the droplets in the air in the environment. If you have a video laryngoscopy, it should be used because it limits your proximity to the airway. Of course, put a bacterial filter on your circuit or on any oxygenation interface. How do we pre-oxygenate these patients? A high flow oxygen should be avoided above 10 liters, because above 10 liters, there is aerosolization. So keep a reservoir mask with a flow oxygen below 10 liters, let the patient breathe spontaneously, and then go on. As I said earlier, don't allow non-critical staff in the room. Do not bag the patient, never bag mask the patient, because it can be very dangerous for you. And only the most qualified and skilled physician should perform the intubation. After intubating the patient, avoid disconnect the circuit. If you have to, always remember to clamp the endotracheal tube, stand by your vent, and after disconnect the circuit. After the surgery, don't bring your PPE outside the room, because it could be kind of dangerous. Somebody asked earlier about obstetrics. Well, if the patient has a respiratory impairment, I think it's advisable to go with the tube. The tube is not a big deal, so intubate the patient. If the patient has not pulmonary impairment, you can try a central block like epidural or spinal. Next. As for the equipment, always keep in mind to have your PPE always on. Prepare all the equipment you will need on a trolley. A bacterial filter on every interface, and this is very important, a closed suctioning circuit. Actually, you won't have to suction your patient, because this patient have very little secretion. So this will not be necessary. But if you have to, make sure you have a closed circuit, a closed suction circuit. As for the technique, as stated earlier, modified rapid sequence intubation. Awake intubation is not advisable because it can take time, and you have to be kind of skilled with the fibroscopy. Avoid back mask ventilation, and above all, wait until your cuff is on to ventilate. Go on. Next. Okay, drugs. Emiliano stated earlier that many patients have hemodynamic derangement. We don't know why yet. This might be due to viral myocarditis. So we choose to use the ketamine, which has a minor hemodynamic impact. Also consider that many patients have a lot of comorbidities, they are obese, so ketamine can be the right hypnotic drug. As neuromuscular blockers, we use suxametonium or rocuronium. Use a higher dose because you have to ensure a optimal relaxation to intubate your patient in less time as possible and avoid him coughing. As for maintenance, we use a total endovenous anesthesia, and I would suggest you to avoid the desfuran because it has a airway irritability effect. Next, please. How do I ventilate a COVID patient? They have a very compliant lung, so they are very good PEEP responders. Set a lung protective ventilation, 6 millimeters per kilo of ideal body weight. Set a high PEEP in order to keep the alveoli open, and keep your draining pressure below 15 and your plateau pressure below 30. Set the fraction of O2 in order to reach at least 65 millimeters of mercury of content of oxygen. Don't forget, at the end of the surgery, to perform recruitment maneuvers. These are very compliant lungs, so you have to recruit them. After the surgery, I think it is advisable to refer the patient to the ICU for extubation because they may have pulmonary impairment, bad gas exchanges, so it is advisable and quite wise to send them to the ICU for the wake-up test. Do not take off your PPE until the patient is out of the OR, and as Dr. Anzalone stated earlier, then a normal sanification can take place. Next. Okay, this is our motto. This is our motto before the curfew was declared by our government. Everything's gonna be all right. Andrà tutto bene. We're gonna pull through. Come on, we can cheer it up. Thank you very much.
Thank you so much. So I'm gonna ask one question and then hand it over to Larry. A couple of you have mentioned that there's a pretty high false negative rate in terms of the testing, and that sometimes there's it shows up on CT scan. So given that the data is showing that, at least what you said, was 50% of patients who are positive are tested negative, are you placing respirator masks and goggles and face shields for all elective intubations, even on patients who may be asymptomatic?
No. We actually, we keep a high suspicion attitude, but if the patient is not positive, we keep the normal PPE. So we do nothing different. We don't have sheets on the vent. We do not have special devices. We just act as we used to do.
So just to clarify.
Yeah, remember to keep a high suspicion because everybody, this is a pandemic breakout. So everybody might have had contacts with positive patients, but I think that a surgical mask will be enough.
Okay, Larry, so it just, again, because for clarification, you're treating everybody as if they have it, and you're protecting, there's two aspects, is protecting the patients and then protecting the staff. So the context of the question is protecting the staff. Yeah. Are staff wearing special masks, like the,
yeah,
they are, and goggles. So that's
the FP3, okay. The FP3 masks.
Okay.
Foxtrot Papa 3.
Okay, so the answer to the question is all staff is wearing full protection, treating as if, even if, as if the patient may have COVID-19.
Yeah, of course.
Okay.
They have had contacts with positive patients because this is a pandemic breakout. Even if we are not on the front line, we are quite close. And this is a great concern. I will share my experience with you. Before the curfew was declared by the government, I told my wife to go away with my baby daughter to a country house my relatives have, because, you know, it would be kind of tough to go back home at the end of the shift and kiss my baby daughter. So this is a big for our relatives.
Okay. Dr. Chu, would you, any other questions from the audience?
Yes, we do have some questions.
Okay.
With the national lockdown, how are you dealing with blood product shortages?
With? Pardon?
Have any shortages of blood?
Huh?
Any
Okay.
shortage of blood?
They are donating blood, yeah. Few, yeah, there are fewer than the past, but they are still donating. They are still donating, yeah, fewer than the past.
Was there a need to do a tracheostomy in any of your patients?
Yeah,
And
of course, we perform early tracheostomy. Actually, our average is on the 3rd day after hospitalization for the ICU patients.
And is there anything that you want to share about that
Yeah,
process?
but this is a local protocol. Of course, this is our experience.
What percentage of the hospitalized COVID-19 patients have needed the helmet CPAP or BiPAP?
Quanti? I think about 10%. 10%, yeah. If
And
we
can you
intubate them in the ICU, then we perform a tracheostomy because it is kind of easier to wean them from the vent.
Can you tell us about the non-invasive ventilation requirements and how you're managing that?
Yeah. Yeah. Actually, yeah, we put our PPE on and then we enter the room, and all the nurses and the staff, the medical staff, so surgical cap, eye shield, FP3 masks, waterproof gown, and cover on their shoes.
Can you talk a little bit about how you make decisions in balancing the risk of procedures to the staff who are involved in doing the procedure compared to the diagnostic value? For instance, aerosolization of the virus during lavage.
If the procedure is needed, we don't think about the consequences. We do what's best for the patient. If we need that broncholavage, we do it, we perform it, no matter the risk for us. No fear.
Larry, can I ask a follow-up question to that? Is the lavage, given that the clinical picture for COVID-19 is pretty strong, what is the value of the lavage and what are you looking for in particular? If you could walk us through that process as to when you do it.
It is very important also for bacterial superinfections. So it can be very useful for us because they can undergo VAPs, ventilator-associated pneumonias. So a broncholavage can be quite diagnostic to start an antibiotic therapy.
So just to clarify, the clinical picture is a patient starts getting secretions, which is suggestive of a bacterial super infection, in which you then need to speciate, and at that point you do lavage, but you're not doing lavage. Go ahead.
Repeat, please?
So I just wanted to get specificity on the circumstances. So most patients are without secretions, but
Yeah,
then you may get a patient now who's developing secretions.
yeah, of
And
course.
at that point, you're suspecting a bacterial, like a ventilator-associated pneumonia. At that point, you do the lavage to speciate the bug, and that's when you're
Yes,
doing.
you got it.
Lavage.
You
Is
got
that
it.
okay? Okay.
Do you have data on how many anesthesiologists have become infected, given that we are likely performing most of the invasive procedures compared to other healthcare workers?
So far, none. We are a crew of 50 anesthesiologists, and so far, no one is infected. We are kind of lucky after 2 weeks.
Do you have any idea why that might be?
Because we protect ourselves very well. We are very concerned about protection. We had time to prepare ourselves because the breakout here arrived a few days after than in Northern Italy. So we have time to prepare ourselves.
Are there other healthcare workers at your hospital that have been infected?
Yeah, 5% of the physicians working in our hospital.
But none of them are anesthesiologists.
No, none.
All right. And then one last question. Patients usually have drops in function at least 24 hours prior to decompensation. Do you see acute drops in function right before death or days preceding?
Yes, yes. This is kind of typical. Actually, they are in their bed reading the newspaper, and then suddenly they have respiratory distress. This is kind of typical. So there is an immediate drop.
So it's an acute drop.
Yeah.
Okay. All right, back to you, Bassam.
Yeah, there was one more question, Giovanni, that I wanted to ask. You mentioned that your family, in a way, you sort of quarantined them there in the country.
Yeah.
Does it make, so the question that we have is, does it make sense for healthcare professionals, if they are symptomatic, to sort of go, instead of back home, but go to a hotel? Or another question is, are staff and faculty deliberately not going back or staying away from their families?
Yeah, this can be an option. In fact, a few physicians who work here have decided that this is not for everybody. I decided to send my family in the countryside because it's much more secure. So I think I took the right decision, because now I can go home and touch everything and contaminate everything. But of course, this is kind of personal. It's personal. This is my opinion.
And in how much time are you planning to adopt this, I guess, personal protocol you've implemented?
Personal protocol. No, will you repeat, please?
Are you planning to do this for 1 week, 2 weeks, 1 month, 2 months?
Okay. I get you. Gotcha. Actually, I will wait for the government to retire the curfew. So when there is no curfew, I will let my family come back to Cesena.